As against benign positional vertigo, where the vertigo is only positional change. In vestibular neuronitis, it is a continuous symptom of a vertigo.
Yes, sir.
So when the patient says patient has imbalance and standing and while walking, it could still be a vestibular neuronitis. Okay.
Okay, sir.
So the ataxia which she is talking about can be vestibular ataxia.
Yes, sir.
So at that point of time, when there is an acute onset of real vertigo because of the spinning, the possibility is vestibular dysfunction at the nuclear level or at the nerve level or at the end organ level. And because it is acute onset, not related to position change, it is not BPVV, it could be an acute vestibular neuronitis as the first diagnosis. If there is an associated hearing problem, it could be the first episode of Meniere's disease. You understand? It
Yes,
could
sir.
be the first episode of Meniere's disease. But in Meniere's disease, there is no continuing ataxia. So it could be vestibular neuronitis or involvement of vestibular nucleus at brainstem level. It requires more localization to brainstem, as you rightly said, diplopia, dysarthria, hemiparesis. If any of those are there, then we say, okay, it is at the brainstem nuclear level. If none of them are there, then it means it is only a vestibular neuronitis. It is simply like a Bell's palsy or a third nerve palsy or sixth nerve palsy, isolated cranial nerve palsy.
Okay, sir.
Right. So at this point, you will say vestibular neuronitis, but you would like to look for, how old is she?
49 years old, sir.
49 years. So vestibular neuronitis slash brainstem involvement, we'll look for the other associated features. Okay, next.
After going home, patient gives history that she was confined to bed completely and was fed dinner by her son. And then she went to sleep at 10 p.m. The next day, patient at 9 a.m., patient noticed that her left upper limb was weak while she was trying to lift a small bucket off of the floor. And that is when they presented to us in the hospital.
So now, what does this left upper limb weakness mean?
Sir, it could be, this is motor weakness, sir.
Yeah, where is the localization now?
Since there is also vestibular involvement from the previous history, I would like to localize it to the brainstem, where there is corticospinal tracts.
Very good. So to recollect again, because of the spinning and vomiting, we said vestibular dysfunction. And because it is acute onset, whether it is a vestibular neuronitis or first episode of Meniere's disease or a brainstem involvement. And ataxia is just a vestibular ataxia. It could be any of the three places. But the left upper limb weakness definitely localizes it to brainstem. You see, you understand now?
Yes, sir.
Because in neurology, we always say, tell me who your friend is. Now there is a vestibular dysfunction and the friend is a left upper limb paresis. So this cannot come by vestibular nerve, nor it comes by inner ear. It has to be in the brainstem. So now we have a definite clinical localization that we are dealing with a brainstem lesion of an acute onset. Because it is acute onset, it is a vascular. Okay.
Yes, sir. Yes, sir.
So you know now neurology is so easy. Only on history you make a diagnosis in 85%. Right. Next.
Yes. So patient did not give any history of difficulty of holding of objects in the right hand or any slippage of slippers, any difficulty in getting up from sitting position. Patient can feel her clothes and is not giving any history of tingling and paresthesia. There is no history of blurring of vision, diplopia, numbness, paresthesia over the face, difficulty in chewing, deviation in angle of mouth, dribbling of saliva or food from the mouth. There is no history of any hearing loss, ringing sensation in the ear, difficulty in swallowing, change in voice and looking from side to side. There is no complaints of swaying while sitting and any involuntary rocking movements. No complaints of any nausea, vomiting. No complaints of any involuntary jerky movements, headaches, and loss of consciousness. No complaints of any palpitations, chest pain, and shortness of breath. And there is no history of any recent fever, rash, or any chronic cough.
You see, whenever you take a negative history, it should be relevant to the patient's story. Okay, not a complete list of 1, 2, 3, 4 like that. Now, because you have localized it to the brain stem,
Yes.
obviously the questions you ask is for further localization in the brain stem, like midbrain. Now, where is the vestibular nucleus situated in the brain stem?
Pons, sir.
In the pons. So, what are the other
Pons.
cranial nerves in the pons?
Trigeminal, lateral, six nerves, sir. Five, six, seven, eight.
Five,
These are
six,
there in
five,
the
six,
pons.
7. So, you ask for specifically symptoms related to dysfunction of fifth nerve, sixth nerve, and seventh nerve. And because we are talking about an acute onset vertebrobasilar territory, you also ask for midbrain symptoms and brainstem symptoms, like what you
Yes, sir.
said, diplopia and all that. Now,
Yes.
you would like to rule out something in the inner ear, so you ask for hearing loss, ringing, and all that. Uh, Difficulty in swallowing, that is the medulla part of it. Now,
Yes, sir.
what is this involuntary jerky movements, headache, loss of consciousness? Why did you ask these questions?
Sir, because patient is giving history of imbalance while standing and walking,
Hmm.
I wanted to know if the patient is also having any truncal ataxia. Since the imbalance during walking is indicating gait ataxia, I wanted to look for truncal ataxia and titubation. That's why I asked this history of swaying while sitting and involuntary rocking movements.
That I
And
agree. What
for
about the jerky movements, headache, loss of consciousness?
So this is these are the symptoms of raised intracranial pressure, sir. I want to make sure that because this lesion is in the posterior circulation, there is a chance of the ventricle, fourth ventricle, to get blocked because of edema, which can lead to raised ICP in the patient. That's why I asked for these symptoms.
Okay. What about this palpitation, chest pain, shortness?
Because I'm thinking this is a vascular cause, I want to rule out cardioembolic if there is any preceding history. That's why I asked for cardiac history, sir.
So, yeah, good, but that comes under past history, not
Okay,
in
okay,
the
sir.
acute history, isn't it?
Okay, sir.
Suppose the patient had a severe chest pain, palpitation, shortness of breath in the morning, and all these
Hmm.
have happened in the evening.
Okay.
So, what does that mean?
Sir, it could be a cardioembolic stroke, sir,
Very good,
because
very good. So, a patient might have had acute MI with a
hmm,
endomural thrombus, and there may be a dislodging of the thrombus. Normally, the thrombus which gets dislodged enters the carotid circulation because that is a larger vessel than vertebral. But
yes, sir.
occasionally, theoretically speaking, it can be a cardiogenic embolus causing the posterior circulation stroke. So, from that point of view, it is of some importance to know whether a patient had a vascular disease in the past. Then it becomes a past history. Palpitation, chest pain, shortness of breath becomes important in the past history.
Yes, sir.
Okay. What about the fever, rash, and all that?
Sir, the patient is also having some motor weakness, and I wanted to rule out any case of labyrinthitis or neuritis, any kind of preceding infection which has triggered this episode of
No, no, no,
sudden
no, no,
neurodeficit.
no, no, not at all. You have already said patient has got a left upper limb weakness, isn't it?
Yes, sir.
So you have ruled out peripheral involvement. You have already focused into the brain stem.
Okay.
So any relevant question should be localized to the brain stem problem.
Okay, sir.
So fever, rash, chronic cough, some viral infection with viral vestibular neuronitis, agreed. Or
Hmm.
patient who has a isolated cerebellitis. It can be post or para-infectious, especially in
Yes.
children. Measles and all that patient can have post-infectious or para-infectious cerebellitis, isolated cerebellum involvement. But the moment brainstem is affected, so it is very unlikely.
Okay,
Okay.
sir.
That's why always I tell the students that ask always relevant questions. You will ask relevant questions only when you have made some clinical diagnosis in the initial part of the history. Okay, let's move on.
Okay, sir. Past history, she is a known case of diabetes since 4 years on glimepiride and metformin, and a known case of hypertension since 4 years on tablet amlong. there is no history of similar episodes in the past, any previous history of strokes or seizures or coronary artery disease. There is no past history suggestive of any TIA.
Now, it's a very important point you have asked. No history suggestive of TIA. Why is it
Yes.
important?
Sir, strokes can be preceded by TIA, sir. TIA can be a warning for a stroke. So if we have a history of TIA, this time we can suspect strongly stroke in this patient.
You are right, but not completely. There are two types of stroke, isn't it? One is a hemorrhagic stroke, another is a stroke with infarction.
Infarction.
Between the two, the stroke of emboli and infarct is about 80%. Hemorrhagic strokes are 20%.
Hmm.
So if the patient had a similar history, transient ischemic attack, it
Hmm.
goes very much in favor that this patient's present problem is a ischemic stroke.
Hmm.
So
Yes, sir.
if there is no past history of TIA, it does not say that it is ischemic or hemorrhagic, but
Hmm.
definitely past history of TIA certainly means that we are dealing with a ischemic stroke. So that is why the importance of asking for previous history suggestive of TIA. So you have asked the question correctly and you have answered, but partially. So TIA is to differentiate ischemic from hemorrhagic stroke. That is the answer. Okay, next.
Yes, sir. Personal history, mixed diet, the appetite and sleep are adequate, bowel and bladder movements are regular. Menstrual history, patient is postmenopausal, attained menopause at 47 years of age. Family history, no similar complaints in the family and no history of any seizure disorder, strokes or coronary artery disease in the family.
Why do you want
So
similar
summarize.
history? Go back, go back. What
Yes,
is
sir.
this similar complaints in the family means what?
Sir, if there is similar complaints like complaints of sudden onset of
No, no,
focal
see,
neurological
look here,
deficit.
you have already made a diagnosis that it is a acute, probably ischemic stroke in the vertebrobasilar territory.
Yes,
So
sir.
how does the family history tell it is something to do with family history?
So the underlying cause of the stroke can be indicated by the family history, sir.
No, at best you can say that there is no family history of hypertension, diabetes, but it doesn't mean that somebody in the family has a stroke. This patient also should have a stroke. It is not
Yes, sir.
hereditary or familial. It is familial maybe because patients have hypertension in more than one member.
Okay,
Okay.
sir.
Okay, right.
Summarizing our history, a 49-year-old female, known diabetic hypertensive, presented with complaints of vertigo and gait ataxia on 16th of August and left upper limb monoparesis since 17th of August. There was no history suggestive of vestibular system involvement or weakness of other limbs or dysfunction of the sensory system or of the brainstem or the cortex involvement. Currently, the patient is confined to the bed. So, sir, actually, I was thinking this is a lesion in the cerebellum, sir, because
One,
patient is complaining of severe ataxia and bilateral ataxia. That is her main complaint. Giddiness was only one episode.
one
So
minute.
I started thinking, yes, sir.
You said no history suggestive of vestibular system. All through you are
Oh,
saying that the patient's presenting symptom is a vestibular dysfunction. We are trying to localize whether it is a nucleus, nerve, or end organ. Now you are writing no history suggestive of vestibular system. Why?
so the thing is, I thought it is probably not vestibular because patient is not having associated symptoms of nausea and vomiting. And the ataxia like that the patient is describing is bilateral and severe.
No, no,
It's
no.
severe enough.
The important is the patient's very first symptom is a spinning sensation.
Yes, sir.
If you have used the word spinning sensation, that means it is a vestibular system involvement. And you have also in the discussion localized the vestibular system involvement at the nuclear level because the patient had a left upper limb weakness. Now you are saying that no history suggestive of vestibular system. Of course, it is there, isn't it?
Yes, sir.
It is a
Yes, sir.
vestibular system involvement. Now, no
Yes, sir.
history suggestive of weakness of other limbs. Okay, that doesn't matter. No history suggestive of brainstem involvement. Why you are saying no history suggestive of brainstem involvement?
Sir, again,
Where
sir,
did
I
the
was
left
thinking,
upper limb weakness come from? All through you have said no brainstem pons, and now you are saying no history brainstem involvement. Why? If
sir,
brainstem is not
right?
involved, cortex is not involved, from where the left hemiparesis has come? You understand?
Yes, sir.
Cortex is not involved, so it is a left upper limb weakness not due to motor cortex. Brainstem is not involved, so how has the left upper limb weakness has come?
Um, explain that, sir. I
Isn't
didn't
it?
explain that, sir. Yes,
So
sir.
you have to remove that word. No history
Yes, sir. Yes,
suggestive of vestibular system is wrong, and no history suggestive of brainstem involvement is wrong, because all through up to now the discussion you said is a vestibular dysfunction at the nuclear level because the patient has a left upper limb weakness. Patient has ataxia, whether it is a vestibular ataxia or cerebellar ataxia, that we'll have to see on the examination. Okay.
yes, sir.
Now, how do you differentiate vestibular ataxia from cerebellar ataxia?
Um, so history wise, vestibular ataxia will present with complaints of vertigo with nausea and vomiting, sir. That is the main
No, no.
complaint.
Patient with a vestibular ataxia, for example, vestibular neuronitis, which lasts for anywhere between 2 to 6 days. So there
Yes,
the
sir.
patient has definite symptom of vertigo while sitting, while standing, while lying down, and also has ataxia associated with vertigo. Okay.
Mhm.
Whereas in cerebellar, they do not have vertigo at the onset, maybe because of vestibular dysfunction. But in sitting and lying down, they don't have any vertigo at all. Only while walking, they have ataxia. So that is how you differentiate a vestibular ataxia from cerebellar ataxia. Okay.
Okay. Yes, sir.
Now, the final part you said inference is lesion in the cerebellum. Again, see, the problem with you students is that you know the final diagnosis. So you try to put everything in the diagnosis from the investigation. Up till now, you have been telling vestibular dysfunction, vestibular nucleus, brainstem because left upper limb is affected. And now suddenly you are changing to lesion is in the cerebellum. Now, how can cerebellum lesion produce a left upper limb weakness?
Cerebellar lesion cannot produce weakness, sir. It will only
So
produce
why you are
deformity.
doing this? Because you know the final diagnosis. So if you know your final diagnosis in the examination, all your thoughts are clouded. You're always focused into your final diagnosis, which you have seen in the image. Please remember to know how to analyze the case. The purpose of my class is to analyze how you should go about when you see a new case. So don't write lesion is in the cerebellum. You say the lesion is in the pons because the patient has vestibular dysfunction and a left upper limb weakness. So which part of the pons should be affected? If it is a left upper limb monoparesis, which part of the pons is affected, right or left?
Right, sir. Right side of
Right.
the pond.
So you should say that in the summary, it is in the right pontine lesion, even without examination. It is a right pontine lesion because of the left upper limb paresis and vestibular dysfunction. I would like to know whether it is associated cerebellar dysfunction is there or not. Now, how do you make out before examination whether the patient has cerebellar dysfunction? Ask for upper limb dysfunction. Suppose the patient is unable to take food to the mouth because of ataxia in the upper limb. That is definitely cerebellar involvement. Cerebellar involvement is in addition to the pontine involvement because both are supplied by the same blood vessel. You understand?
Yes, sir. Yes,
So,
sir.
is there in the history the patient has difficulty in eating food or brushing or any of these upper limb activity? History
Yes,
wise,
sir.
history wise.
Yes, sir. She's giving history that after she went home, her son fed her the dinner because she was unable to eat. It was too much of, it was very difficult for her to able to take her own food. So she was confined to bed and her son fed her.
So you have got a point there that the
Yes, sir.
patient has definitely cerebellar plus pontine vestibular involvement, isn't it?
Mhm. Yes, sir.
So the patient has a right upper limb ataxia cerebellar is ipsilateral, and left upper limb monoparesis, pyramidal tract crosses, and so the localization is to the right pons,
Right form.
plus minus cerebellar involvement. Okay,
Okay, sir. Okay,
so
sir.
the main localization is in the pons, not in the cerebellum. And why do you
Yes, sir.
put a question mark vascular cause? It is definitely vascular because it is acute onset. Anyway, for all the students who are joining here, I am restarting again at 6:45 because the present time is running out. So don't think that we have finished the presentation. We'll come back at 6:45 as soon as the time runs out. So don't say question mark vascular cause. Be confident. It is acute
Yes,
in
sir.
onset. Anything in neurology acute is only two. One is vascular, another is traumatic.
Okay,
Okay,
sir.
not only
Yes, sir.
acute, this we can call it as a hyperacute. Abrupt onset, I think that's the right word. Abrupt
Abrupt.
onset is either a traumatic, that means the patient has fallen down, head injury, and developed all this, or it is a vascular. Something acute over a period of several hours can be a lot of them, infective, inflammatory, demyelinating, etc., etc. But this sort of an abrupt onset is vascular, vascular, and vascular because there is no history of injury, right?
Yes, sir. Yes, sir. No
So
history.
don't put a question mark, right? Vascular cause, a little more in detail. What vessel and what type of pathology? Which vessel?
Um,
Carotid or
vertebro
vertebrobasilar?
vertebrobasilar
So
system, sir.
you can say that even in summary without examining the patient. So you say vascular, territory, vertebrobasilar, type of
Yes.
stroke. Is it ischemic or is it hemorrhagic?
So could be either, sir. She is a hypertensive as well.
Hmm.
But it could be either, sir. I am not.
Which
I
is
don't know
more
if I can
likely?
comment.
Which is more likely?
Sir, in this patient, ischemic, I
What
would
are
say,
the
because
sites of hemorrhagic stroke in posterior fossa?
sir,
What are the,
cerebellum, sir.
one is cerebellum,
Hemorrhagic,
another
yes,
is
sir. Pons,
pons. Now, what is the localization here?
pons.
Pons. So, can hemorrhage occur in the pons?
Yes,
Answer
sir.
is yes. But what would be the usual clinical feature in the pontine hemorrhage? The patient is much more moribund. They will be in unconscious state
Yeah,
because pontine
correct.
hemorrhage cuts off corticospinal tract on either side, and so they will be quadriplegic in an unconscious state. It is usually fatal. So that is what
Hmm.
we have been taught in the pre-MR scan era. But we do see in clinical practice occasionally a small bleed in the pons manifesting as a ischemic infarct. Going by the
Okay.
commonality, you can say that the lesion is in the pons plus minus cerebellum, right side of the pons, acute onset vascular in the vertebrobasilar territory. Most likely, it is an ischemic lesion because the patient is, in case of hemorrhage, it will be much more moribund. Okay,
Yes, yes, sir.
so that should be your complete presentation after the summary. Right.
Yes, sir.
Let's see. We still have a few minutes left.
On general physical examination, patient is comfortable lying on bed. Afebrile, vitals are all normal, sir. Just BP was slightly high, 150 by 80 in the right arm, supine
Okay, so
position.
all those are okay. Now the last line, carotid bruit absent.
Yes, sir.
Suppose carotid bruit is there. What does
Oh,
it mean for you?
actually, sir, in this patient, it's not significant, sir. This is
Pardon?
just a routine exam. In this patient, it's not significant, sir, because we are suspecting vertebrobasilar territory involvement.
Very good.
This was just a
So
part done as a part of routine.
presence of carotid bruit or presence of carotid stenosis in Doppler or presence of carotid stenosis in MR angiogram or CT angiogram is of no clinical significance in this patient for the presentation of the symptoms. Okay? Hello.
Yes, sir. Yes, sir. Yes, sir.
It only means that the patient has atherosclerotic narrowing of the blood vessels presented in the vertebrobasilar system, but also it is there in the carotid system. Suppose this patient has carotid stenosis of 70%.
Hmm.
What would you do?
Sir, Nothing, sir. It's not, nothing is indicated for 70% plus patient is not symptomatic. I'll ask them to follow up, but I will not intervene presently.
So that means it is a asymptomatic carotid stenosis, right?
Yes, sir. Yes, sir.
So asymptomatic carotid stenosis, generally we don't tackle them by any invasive procedure like stenting or endarterectomy. Symptomatic, yes. Suppose the patient has a left hemiparesis due to right cerebral infarction and right carotid artery, there is a 70% plus stenosis. Then we do either endarterectomy or stenting. But asymptomatic carotid stenosis, we don't usually touch. We only tell them to prevent further problems, excellent control of underlying causes. Okay, next.
Yes, sir.
Srinivas sir ಅಂತ ಹೇಳೋಣ.
On general examination, pallor was present, sir, but no other signs, no icterus clubbing, cyanosis, polymicria. On neurological examination, higher mental function, sir, MMSE score was 29 by 30. Cranial nerve
What are
examination,
the positive neurological findings?
sir, the ninth nerve, sir, on ninth and 10th nerve examination, the palatal arch on the left side was lower when compared to the right side, but the uvula was central, and bilaterally gag reflex was present, sir. And on examination, eighth nerve did not give any findings, sir. So bilaterally, patient could hear finger rubbing. Dix Hallpike was done, which was negative, and vestibular ocular reflex was also bilaterally negative, sir. And there was no nystagmus.
Yes, please. Full screen.
Yes, sir. Okay. On motor system, sir, cranial nerve, sir.
No,
On examination,
because we said Fontaine, no. So we should look specifically for 5, 6, 7. Did you find any 5,
yes,
6,
sir,
7
nothing, sir, nothing. All normal, sir. Nothing
5,
is
6,
there
7
in
is
5,
normal.
6.
Right.
Yes, sir. 5, 6, 7 is normal.
Okay.
Eighth nerve is also normal on examination.
Right.
Ninth and 10th nerve examination, I could see the palatal arch on the left side was slightly lower when compared to the right side, but the uvula was central and gag reflex was present bilaterally, sir.
Okay, so it is not of any significance because please note that if the patient has a palatal palsy, what question you should ask in the symptom?
Sir, nasal regurgitation of the food.
Yeah,
Any
nasal
cough
regurgitation and nasal twang of the speech.
twang.
If
Yes,
it
sir.
is there, then it is something to do with the palatal problem. Otherwise, a slight difference between the left and right arch has got no specific significance
Okay,
on
sir.
its own. Okay, right.
Okay, sir.
Other cranial
On motor,
okay,
normal, sir. 11 and 12 normal.
right.
On motor system examination, bilaterally the bulk is equal. So these are the measurements, they were normal. There were no fasciculations or abnormal movements noticed. Tone on examination, bilaterally there was a spastic tone in all the 4 limbs, sir. More on the left side when compared to the right. Modified Ashworth score grading is grade 2 on the left side and grade 1 on the right side, sir. All the 4 limbs. And on examination of the power, right upper limb, the power was 5 by 5 in all groups of muscle. Right lower limb, the power was 4 plus by 5 in on group muscles. In the left upper limb and lower limb, power was 4 minus by 5 in all muscle groups.
So
Sir,
what
I
is-
tried looking for
Uh,
pronator drift in the right upper limb, sir, which I didn't find. There was no pronator drift.
what about where is it present at least that you have not mentioned? Pronator
Sir?
drift is present in the left upper limb.
No, sir, both. When I examined, it's not going in both the limbs actually.
Then there is no need to say right upper limb absent. So which denotes
Okay.
that there is left upper limb is present. Instead of focusing on negative aspects, even in life, you should always focus on positive things in life. Don't go on to the negative things and feel depressed. Look at the positive
Yes, sir,
things
yes.
you have. Similarly, in the examination also, most important is what is positive. Then if something is absent, then you can focus on that. Okay, now
Yes, sir.
bilateral spasticity and left side more weak than right. What does this mean?
Sir, spastic weakness indicates corticospinal tract lesion, sir.
Very
And
good.
this is indicating bilateral right cortico spinal tract lesion, we can tell, because we can explain the left weakness. The
Correct.
right lower limb weakness, I'm not sure, sir. I don't know how to explain this.
Those fibers are more affected, that's all. So
Okay.
whenever there is a corticospinal, that means right from the motor cortex to the spinal cord, when the tract is affected, you will get a hemiparesis or monoparesis of a UMN type. Now, where do you think is the lesion? Corticospinal tract, right from motor cortex down to the spinal cord. Where do you think the corticospinal tract is affected in this patient?
Sir, since we, through the history, we localized it to pons, I will say pons.
Why?
Uh, sir, two things. Sir, first thing was vestibular nerve dysfunction that we were discussing. Second thing is cerebellar involvement
Very
that we were
good.
suspecting.
So,
Both of them will.
very correct. So, whenever it comes to localization in stroke, again back to the same adage. Tell me who your friend is, who I will tell you who you are. If the patient has a cortical involvement, then there may be hemiparesis, focal seizures, and all that. But we are saying that it is in the pons because the presentation of is vestibular nuclear dysfunction situated in the pons as well as cerebellar involvement, both supplied by the same blood vessel. So in this case, the corticospinal tract is involved in the brain stem. You understand?
Yes, sir. Yes,
So
sir.
when you do an MR scan, you focus more on the brainstem localization.
Yes, sir.
Whenever I give a request for a MR scan, I always mention what is my anatomical localization, and I tell them area of interest, pons and cerebellum in this case. So if there are mild, not in this case, suppose there is a demyelinating plaque, which may be missed just by looking at an MR brain. But if you say area of interest is pons and cerebellum, they will go into they will blow up the image of the pons. The radiologist can blow up the image of the pons and then make it bright and nice and then try to look at a demyelinating plaque which may not be seen as soon as you look at it. So there is a important thing is to always help the radiologist to know where your anatomical localization is. Just writing
Yes,
MR brain, it doesn't mean anything. You have to write area of interest, pons and cerebellum. Clinical diagnosis, ischemic infarct. Then they will be able to tell you, is it an infarct? If so, how many days old is the infarct radiologically? So please always, when you give any investigation request, write your diagnosis and anatomical localization. Okay?
yes, yes, sir.
Right, let's move.
Then sensory system examination, pinprick, cotton touch, vibration sense,
All
and
are normal.
proprioception were present. Yes, sir. Everything was normal.
Right.
Reflexes, sir. Right side up tricep, bicep, and supinator jerk was 2+. The knee jerk and the ankle jerk on the right side was 1+. Left side, all the reflexes, deep tendon reflexes were 3+, sir. Plantar on the left side showed extension, but on the left side was showing flexion.
Okay, so that means the patient has got more involvement of right corticospinal tract, causing more
Yes,
left-sided hemiparesis. Right. Okay, next.
okay. Cerebellum examination, sir. First, I examined the patient on sitting. No truncal ataxia was
If there is
noticed.
a truncal
The
ataxia, where is the lesion?
worm, sir, of the cerebellum.
Right. Good.
Okay. Intentional tremor was present. Finger nose test, finger test, both showed bilateral incoordination. Pass pointing was also present. Rebound phenomena was present. More on the left side on the right. Bilaterally dysdiadochokinesia was also present, sir, but no nystagmus was noted.
How do
On
you
lying down,
differentiate?
sir.
How do you differentiate an intention tremor from an essential tremor?
Sir, essential tremor is present at rest. Intentional tremor starts
Wait.
only at.
What's it? Say again.
Sorry, sir. Essential tremor is present at rest, and
Intention
intentional
tremor
tremor.
is intention tremor is present at rest.
No, sir. Essential tremor is present at rest.
Essential tremor is present at rest. Are you sure? Is that the right answer?
Sir, it actually essential tremor occurs because of sympathetic overactivity, sir.
No, I'm not
So,
interested in theory. There is only one condition which has a resting tremor. What is that condition?
Parkinson's.
Then essential tremor will not be there at rest. The resting tremor is equal to extrapyramidal disorder commonly seen in Parkinson's disease. There is no differential diagnosis once you say there is a resting tremor. Okay.
Yes, sir.
Now, between essential tremor and intention tremor of cerebellar, what is the difference? How do you distinguish? Somebody comes only with tremor. Now you want to know whether it is a cerebellar tremor or essential tremor.
Sir,
Anybody in the
intentional
chat box
tremor.
also can answer, please.
So intentional tremor occurs only on movement, sir.
Relieved by beta blockers is a therapeutic test, clinical. Intention tremor stops at the end of activity. On the contrary, the intention tremor becomes violent at the end of the activity. Okay. So
Okay, sir.
the essential tremor is the most common tremor in clinical practice. Essential tremor is a tremor on outstretched hand, what is called as a postural tremor, positional tremor. So when you ask the person to outstretch his hand, then there will be mild tremors or violent tremors. Okay. When the hand is resting, there is no tremor. And if the essential tremor is very violent, they also have difficulty in drinking the water. But most of the essential tremors which are mild does not come in the way of taking the water and food. Intention tremor, I always compare it with our earlier hockey team. There is an intention to score a goal, but the moment you reach the goal, it doesn't fall through. You understand? It doesn't materialize. So similarly, when a person starts taking a morsel of food to the mouth, as it reaches the goal, that is the mouth, then there is a violent tremor causing the food to spill. You understand? So whenever there is an intention of a particular activity, the tremors become more as the goal is being reached. Whereas in essential tremor, they can still continue to drink water and take food unless it is an extreme degree of essential tremor. So normally the essential tremor does not interfere with eating food or drinking water. Sorry, somebody said
Okay,
essential
sir.
tremor is diagnosis of exclusion. Certainly not. Essential tremor is diagnosis by clinical history that the patient has tremors when he is holding a plate in the buffet dinner. When he's holding a plate in the buffet dinner, the plate starts shaking. It happens even in anxiety. Okay. When a person is holding a pen to write, they start shaking. But when it is at rest, no. So in spite of that, they are able to eat food and all that. If it is associated, somebody has written very nicely, whenever there is a tremor with titubation, head tremor, it is always essential tremor. So if you see the patient has come to you for essential tremors, as he's sitting in front of you, you can see the head shaking like this, titubation, then you know that it is an essential tremor involving the limbs as well as the head. Occasionally, it can also involve the voice. So tremor with head is essential tremor. Tremor with difficulty to eat food and all that, but outstretched hand is not much of a tremor. But when they start going to the goal, it starts shaking. Now that is the intention tremor of cerebellar. Because very important to differentiate in the clinical practice because intention tremor is, I mean, the essential tremor is very common. In about 20 to 30%, it is also familial tremor. So the patient may have a family history, which will add to the diagnosis, but the primary diagnosis is on the patient. Okay, let's move.
Yes, sir. On lying down, heel chin test showed bilateral incoordination, and there was pendular knee jerk in the left knee. So the patient was able to stand up only with support of two different individuals because she was experiencing severe imbalance. So I could not assess Gait and Romberg's in her, and her speech is normal, sir.
How do you test Romberg?
Sir, I'll ask the patient to stand with her both her feet together, and I will ask the patient to either hold the hands across the body or on the sides, and then I will ask the patient to close their eyes. If the patient experiences swaying on either sides, then Romberg's is positive. It indicates either a sensory ataxia or a vestibular ataxia.
Most important is you must see the stability with eyes open. Majority of you people, what you do, stand there, keep your feet together, close your eyes. Don't do that. Ask the
Yes, sir.
patient to open the eyes and look at your finger. You show your finger and say, look here,
Okay,
and
sir.
see whether the patient is stable. In case of vestibular or in cerebellar, he is not stable even with eyes open. In
Okay, sir.
sensory ataxia, he is stable. The moment he closes the eye, some amount of imbalance is normal, especially in senior citizens. The imbalance to an extent of falling is a Romberg's positive. You understand?
Yes, sir.
You and me also, of course, I am a senior citizen. If I close my eyes with feet together, I definitely feel that I may fall. So
Okay,
that
sir.
doesn't mean it is Romberg's is positive. So Romberg's positive is with eyes open, stable. First, you must look at that. Then with eyes closed, unstable to an extent of falling. Somebody has to be by the side to see that he does not fall down. So that is called as a Romberg's positive is equal to sensory ataxia. With eyes open also, he is unstable. You cannot test Romberg sign at all. Okay,
Yes, sir.
next.
The rest of the clinical
Okay, they're all
examination was normal.
right.
So, final impressions are neurodeficit, UMN left hemiparesis with UMN right lower limb monoparesis with bilateral upper limb and lower limb cerebellar ataxia. So, I thought because the palatal arch is low, the cranial nerve might also be involved.
So there you have
Anatomical
to put a question
localization.
mark because you are not sure whether it is 9 and 10 involved because patient doesn't have any symptoms related to that. You can
Yes,
put a
sir.
question mark left 9 and 10. But your primary diagnosis is in the pons because of the vestibular dysfunction, right? Okay.
Yes, sir.
So
Uh,
neurodeficit is fine. So patient has a UMN cerebellar plus minus 9 and 10. Right.
yes, sir. Anatomical localization in bilateral corticospinal tracts and cerebellar hemispheres or peduncles, sir. I thought medulla because ninth and 10th nerves were involved, according to the examination, or in cerebellum.
Madam, history. In neurology, history is 80% diagnosis.
Yes,
10%
sir.
is examination, 5% is routine investigation, only 5% is high tech investigation. You started off very well, vestibular dysfunction, and you said vestibular is in the pons, and then you are jumping to the medulla because query 9th and 10. If the patient doesn't have symptom of 9 and 10, the primary localization is in the pons. It
Pons.
may it may be associated with 9 and 10 because the circulation is same. Vertebrobasilar can involve the midbrain, the pons, the medulla, and the cerebellum, the entire thing. But what is important is what does this patient have? So we should say anatomical localization, corticospinal tract at the level of pons.
Okay.
And is there a necessity to invoke cerebellar hemisphere, or you can have cerebellar symptoms and signs with the middle cerebellar peduncle which connects the pons. Remember,
Yeah.
cerebellar
Pa-
symptoms can occur in the brainstem because of its connection with the midbrain
connection.
superior cerebellar, pons middle cerebellar, and medulla inferior cerebellar peduncle. For example, in multiple sclerosis, when patients come to us for cerebellar ataxia, the lesion is not in the cerebellum. The lesion is in the brainstem, affecting the tracts of peduncles, cerebellar connection with the brainstem. So definitely the patient has a corticospinal tract. That means brainstem localization is pakka.
Yes, sir.
Cerebellar involvement alone cannot give rise to corticospinal tract involvement. But
Yes, sir.
brainstem involvement can give rise to cerebellar symptoms. You understand?
Yes, sir.
So the localization can be just brainstem only. Because
Okay,
we
sir.
are thinking in terms of vascular, it might have also affected the cerebellum. Suppose the same story is in a 28-year-old young girl, rapidly progressive ataxia, cerebellar hemiparesis, would have thought of a brainstem pakka localization, probably demyelination in MS.
MS.
So please remember, cerebellar signs and symptoms does not necessarily mean hemisphere involvement. It's connections in the brainstem. So here definitely brainstem because corticospinal tract are involved, plus minus cerebellar hemisphere. Right. Pathological diagnosis. Don't put question mark. Be confident.
Yes, sir.
Acute
Yes, sir.
ischemic stroke. But you did not mention territory. Whenever you talk of
But
cerebrovascular accident, remember the territory and the type of stroke. Is it ischemic or hemorrhagic, or it is vascular is vertebrobasilar or carotid artery? Okay.
Yes, sir.
So your pathological
Vertebrovascular
diagnosis is ischemic stroke in the vertebrovascular territory.
Basilar
That is the
artery.
final diagnosis. Etiology is yes, of course, atherosclerosis. You could have added there the precipitating or supportive factors or hypertension, diabetes. And
And
all.
diabetes.
Okay,
Yes,
good.
sir.
So now next thing is, hello.
Yes, sir. Yes, sir.
Yeah, of course, we do all the routine investigations. I always teach two things. One is an investigation of choice for anatomical localization confirmation. Second is the investigation of choice for etiological diagnosis. Okay. So
Okay,
you
sir.
have made anatomical localization, pons plus minus cerebellum. So what is
Yes.
the investigation of choice for anatomical localization? What is the
So
investigation of
this
choice?
this patient came to us after the window period. Her symptoms started on 16th August 6 p.m. She came to us on at 10 a.m. on 17th August. So I would go for a CT scan to look for anatomical localization confirmation, sir.
Okay, tell me, in a stroke, what is your
Yes, sir.
choice of investigation? Is it a CT or is it a MR?
MR, sir. It will give us a better idea of the areas involved.
Why do you want better idea? You already made a very good clinical localization.
Yes, sir. Then we will go for CT. It depends on the window period, sir. If the patient comes within the window period, then we will go for MR. If after window period, we'll go
Correct,
CT.
very correct. If the because CT and MR, see, we said vascular territory. We are looking whether it is a bleed or whether it is an infarct because the management
Yes.
differs between ischemic infarct versus bleed. So
Mm.
suppose the patient has come outside the window period or patients come to us next day of the stroke.
Yes, sir.
No doubt, MR scan will give you more detailed involvement of the territory, etc., etc. But you are not going to do anything in spite of the clear MR images. So in such a case, if MR is not available in your hospital, there is no need to ship the patient to somewhere. CT is the most important diagnostic investigation because it will clearly define whether it is a bleed or an infarct. Bleed will be seen almost immediately. Infarct may or may not be seen. Posterior fossa infarct may not be seen because it is covered by the bone, the occiput. Okay. So CT is normal. Clinical diagnosis is hemiplegia. So by default, it is a ischemic infarct.
Infarct. Mm.
CT shows a bleed and patient has hemiplegia. It is a hemorrhagic.
Hemorrhagic.
But if you are planning for uh, thrombolysis or interventional neurological things like mechanical thrombectomy and all that, which will happen in the during the window period, and
Location.
obviously MR and CT angiogram are complementary. Okay.
Yes, sir.
So what I'm saying is, suppose a patient comes to you next day of the stroke and patient is stabilized, there is no point in wasting 7,000 rupees for an MR scan.
Yes, sir.
I don't do it at all if the patient cannot afford. I will just do a CT scan, make sure that I start antiplatelet because it doesn't show a bleed. Okay,
Yes,
routinely
sir.
don't go on sending to the MR scan in clinical practice because majority of them may not be able to afford.
Yes, sir.
Right. Next, let
So
us see the CT
routine.
scan.
Sir. So this is the video.
Can somebody mute, please? Some background noise is going on.
So this is the
Yeah. So what do you
infarct
see
here.
here? Patient has a
Infarct in the left
so
left
there is a
cerebellum and the
what you are seeing is a hypodense area in the left cerebellum. In view of the story, it is an infarct. So your
yes, sir.
clinical localization is the right pons and patient has a left cerebellar infarct, right?
Yes, sir.
So do you see anything in the right pons?
Uh, Sir, in on the scan, yes, sir.
It's very difficult to see anything in the pons in the CT scan because it is
CT, yes, sir.
closely surrounded by bones.
Mm.
Okay, can you proceed? We have just a few more minutes left, I believe.
Yes, sir.
And for all the students, kindly message me if you are going to present a case for the next Thursday. Every Thursday, 6 o'clock is my class, and the uh, my Zoom is a private one. I have made it so the same IDs, same login, everything is same. All you have to do is Thursday 6 o'clock you can log in. But any of you are willing to present a case, please contact me. Okay, so it shows a left cerebellar infarct. Okay,
Yes,
next.
sir. This is the report, sir, of the CT scan.
Okay, it is already seen in the left cerebellar infarct. Can you move on?
This is the, sir, the patient was given anti-edema for 7 days, sir. She was given 3% saline and mannitol for 7 days. Then an MR scan was repeated for her because the patient was affordable. So this
Yes.
is the MR scan. This is the T2 flare
So which
section,
one you
sir.
would like to see in MR scan? For an acute
DWI,
infarct, you
sir.
look for a diffusion weighted image.
Yes, sir.
Okay.
DWI is also here, sir.
So what does it show?
Here.
There you are. So the patient has a left pontine lesion. So we are all the time saying right pontine because according to you, left hemiparesis is more than right. Okay.
Yes, sir.
So it is a left pontine lesion with a left cerebellar involvement. But remember, clinical diagnosis is more important. There are times when you find definitely the patient has a neurological deficit, and even an MR scan may not show anything initially. So the patient has an acute hemiplegia. You made a diagnosis of a right cerebral infarct. You get an MR scan done. Sometimes MR scan may be normal. It does not mean the patient has a psychogenic left hemiplegia. Please remember, clinical neurology is supreme. Okay. There are times when you find there is a neurological deficit. For example, this patient may have third nerve, sixth nerve, suggestive of a big brain lesion, but MR may not show that. MR is a structure. What we are looking clinically is a function that is more important than a structure. So clinical diagnosis is supreme, not the radiological diagnosis is only add-on. Don't discard a clinical diagnosis. Okay,
Yes, sir.
right. Can we move
These
on?
are the images, sir. Yes, sir. This is the final report of the MRI, sir.
So there is more of involvement of the left inferior cerebellar vermis FS. See here, according to this, there is a vermis involvement. So the patient has a truncal ataxia, right?
No, sir. The patient is actually stable on sitting. On standing, she is having
Earlier in the
impairments.
history, was there any truncal ataxia?
Uh, Sir, patient is giving just sudden onset history of vertigo followed by ataxia. She's not specifically
So we are
saying she
not
only
sure.
had truncal ataxia. Yes, sir.
Okay, now you also do for it. So the way I said two investigations, one for anatomical localization, two for etiological diagnosis. So what is the etiology of stroke in this patient?
Sir, we are thinking atherosclerotic only because the
Due to
cardiac
what?
workup was,
Due to what?
sir, because of diabetes and hypertension. She is a diabetic and a hypertensive that can lead to atherosclerosis. We started her on single antiplatelet and
So
statin.
when the management comes, management of the etiological diagnosis. So excellent control of hypertension, diabetes, obesity, lipid abnormalities, and smoking. So all these risk factors of the stroke must be meticulously addressed to prevent another stroke.
Another stroke.
Now
Yes,
for
sir.
the present stroke, how do you manage?
Sir, patient came to us outside of window period and it is an ischemic stroke. We will start by giving antiplatelet and statin. The question is single antiplatelet or dual antiplatelet. We give dual antiplatelet in cardioembolic strokes. Other strokes, we give single antiplatelet.
No,
That's why
no,
in her
no,
we
no,
started.
no, no, no. Even in patients with a ischemic stroke, the trend is to give two antiplatelets, that is aspirin plus clopidogrel
Clopidogrel.
for
Okay.
3 months, and then only aspirin for rest of the life. Why 3 months? Because the recurrence of stroke is common in the first 1 month, second month, and third month. After that, the recurrence of stroke is uncommon unless the risk factors are not addressed. So the present trend is to give standard dose. We don't give like cardiologist 4 tablets of that, 4 tablets of this, like that. So we give 150 mg of aspirin and 75 mg of clopidogrel plus a statin. Even if the lipid profile is normal, because the statin also helps to reduce the atherosclerotic plaque. So 3 drugs are given for 3 months and then only aspirin for rest of the life. In addition, management of hypertension, diabetes. Is there a role for surgery in this patient?
Sir, because it's a posterior circulatory stroke, I would want to make sure that there is no raised ICP. Apart from that, there is no indication of any intervention, sir, in this patient.
So, in other words, what is the indication for surgery in a vertebrobasilar territory stroke? Okay, because time is running out, I will answer myself. In case of cerebellar hematoma or cerebellar infarct, it presses upon the fourth ventricle and the brainstem, and the patient may lapse into coma and death. So,
Yes.
in this case, in the posterior fossa strokes, either hemorrhagic or infarct, when the patient's conscious level is going down and the scan shows a brainstem displacement, that is the right time to do a craniectomy and to relieve the pressure.
Yes, sir.
And the surgery has got excellent results in surgery in posterior fossa strokes because the patient regains the consciousness and the neurological deficit almost always recovers. Unlike in carotid artery strokes, where the patient has a right cerebral hemisphere massive stroke and patient is lapsing into unconscious, we do a craniectomy there, but with a clear information that hemiplegia will not improve by craniectomy. We are only saving your life, not saving your hemiplegia. That's a very important point to differentiate surgery supratentorial from surgery in the infratentorial. Surgery very valuable results in infratentorial patients. Okay, so in this patient we keep a watch. The edema reaches its peak by second, third day up to seventh day. So anti-edema measures of mannitol is of no use after the seventh day. So if the patient who is admitted conscious state by second day becomes drowsy, by third day he becomes more drowsy, and the scan shows displacement of brainstem by cerebellar infarct, there's the right time to do surgery. But suppose the cerebellum is not affected, there is only brainstem infarct and the patient is unconscious, there is no role for surgery. Is it clear?
Yes, sir. Yes, sir.
Okay, any questions? Or we'll meet next Thursday, just 1 more minute left. Very good presentation, very nice. Anything you want to show us now?
Nothing, sir. Thank you, sir.
Okay, so here we do routinely carotid and vertebral Doppler, but it has got no value because we are not going to do any vertebral artery intervention, and there's no need to do carotid intervention because the clinical diagnosis is in the vertebrobasilar territory.
Yes, sir.
And no use of anti-edema measures after 1 week, even if the patient is unconscious, because the edema factor does not play a role in unconscious state after 1 week. Nothing else. Okay, very good. Tanya, you've done a good job.
Thank you, sir.
If there is any case, you can also present next week, but if somebody else wants to do, please go ahead. I am very eager to teach. I only want somebody to present a case. Most of these talks are there in my what YouTube. Go to the Dr. HV Srinivas neurologist. You can see clinical localization of stroke, management of stroke, etc., etc. You can go through those slides also for more information. Because there is no time, I cannot tell you more about the theoretical aspects. In case of vertebrobasilar, the window period is extended to 6 hours or even more than that if there is an interventional neurology like mechanical thrombectomy.
Yes, sir.
Okay. Anyway, you are in Narayana where there is a lot of vascular